speaker is misplaced in the student trainee oral presentation. He's actually an associate professor, and he's another one of our visitors from across the country from Morgan State University in West Virginia?
Morgan State University.
In Maryland, right? Maryland. Talking about participatory randomization intervention to promote and enhance nicotine dependence treatment in a low-income community using community peer motivators. Dr. Sheikhattari.
Thank you, Dr. Friedman. Good afternoon. So our presentation is about a community-based participatory research project to enhance smoking cessation outcomes among residents of a low-income community in Baltimore, Maryland. It's called CCCs initiative, which stands for Communities Engaged in Advocating for Smoke-Free Environment. Sorry. Okay. So specifically, the title of this presentation is about like the description of the process and some of the major findings of a participatory randomized intervention to promote and enhance nicotine dependence treatment in a low-income community using community peer motivators. Dr. Fernando Wagner is the PI of the project, and he's with me today in the audience, and we both work together at Morgan State University Prevention Sciences Research Center, and I have to say that it was a nice surprise to be listed in the student section because it makes us feel a lot younger. So we present our presentation on behalf of the partnership, which, as you see here, there are representatives from different institutions and neighborhoods in the community, as well as some of the academic partners. Each person is core collaborator, have a different role, responsibilities, and they're organized in different structures that will be described in more detail in the following slides. So you all know that tobacco is a major problem in the United States. There's about like 20% prevalence. 1 in 4 current smokers create nicotine dependence. It's a top cause of the preventable death. There is 400,000 attributable death each year related to nicotine, and it's primarily through lung cancer. And that's also a leading cause of the deaths and morbidities among African American community. And this is Baltimore. For those of you who want to learn more about Baltimore, we have a beautiful, lively downtown, a beautiful, historic inner harbor. We have great sport teams, Orioles, Raven. By the way, we won the Super Bowl. But also we have some troubled neighborhood like any other major cities. As you see here, there are disadvantaged neighborhoods with lots of problems, substance abuse, and other mental health issues. Okay, I think I'm going to skip this slide. This slide is about like the life expectancy in different neighborhoods in Baltimore. As you see here in the right side, that's the average for the Maryland. So there are few neighborhoods in the city that they are above that average, but most of the Baltimore City neighborhoods are below that average. And as you see here in the far left, there are the communities. The 2 red communities are the communities that we are targeted by our initiative, and they have life expectancies like 20 years lower of the better off communities, that they are like 4 or 5 miles apart from that community, and so it's like 62 years of life expectancies that it's comparable to the like developing world. And this is the age-adjusted Baltimore mortality rates, and this is about the disparity reports. As you see in this slide, there is a disparity based on race, based on gender in smoking behavior, but most of the disparities is based on education and income. So our initiative, our partnership actually started in 2002. It was a partnership between Morgan State University and Johns Hopkins Bloomberg School of Public Health. In 2002, these 2 institutions did a survey together, and there was a school-based health fair, which led to a lot of ongoing discussions and health fairs and summits with the community. In 2006, we launched a mini grant program. We funded some of the small community-based projects projects in the community, it gives us a very good reason to systematically be engaged with the community and served as a stepping stone for the successful grant application that happened in 2008, which was this project, and that was the year that we formed the community advisory board for the project. In 2009, we created the subcommittees and designed the intervention. So the intervention launched in 2 phases. The first phase was launched in 2009. It was the first randomized control trial, and the second phase was in 2011. So based on our data, like in average, we have 55% current smoking rate among adults, but there are also 33% that they never smoked and 12% former smokers in the community. But the community, if you look at them, there were some areas that we had as high as 70% of smoking rates among male adults specifically. And so this project has been funded by the National Center on Minority Health, and the SEEDS initiative mission is to create smoke-free environment, smoke-free Southwest Baltimore specifically. And the mission is through providing cessation treatment and as well as some prevention activities, advocacy, and other community education activities. So the community advisory board, as I mentioned earlier, supervise everything, every activities, planning, development, implementation, evaluation of the project. There are 12 members, and we make decisions by consensus. And they also oversee 3 major subcommittees. One of them is responsible for information campaigns and education. The second one is called CCCs, for community connection and outreach. And CAN is more research-oriented, is for community assets and needs, and supervise the randomized control trial task force. So these are different committees, like ICE committee is more to design the information material, CCC committee for outreach activities, some of the outreach activities that we have been doing. CAN committee is like for the assets mapping and needs assessment and the randomized control trial phases. So this is phase 1. That I would like to discuss briefly. So we recruited our participants through many different ways. One was through community recruitments, through flyers, through some outreach to the other groups, create relationship with small businesses, and also through an incentive program to attend the orientation session, as well as a referral program. So they get incentives for referrals as well. But we have also other incentives to ensure retention. We have incentives for attention. We have incentives for follow-ups, as well as for some of the milestones, like if they set a quit date, if they quit for 1 week, and for any subsequent weeks that they remain tobacco-free. So these are the kind of flyers that we use. And this is a randomization process for the phase 1. As you see, there is 2 arms, individual arm, group arms. So they share certain elements in both arms. We provide nicotine replacement therapy and prescription medications case by case. And we have a behavioral management, contingency management program that is similar in both groups. But in one group, we have individual counseling through internists, and the other one, it was a group counseling based on Fresh Start curriculum through a practitioner, a research nurse, and plus a nurse interview. So this is a summary of the results. 437 participants recruited into both arms. We had a cessation rate of about 10%, and I have to say we didn't have a very good retention rate. We had high attritions. Like 45% of our participants attended only 2 or 5 sessions, 14%, only 14% attendance, like 6 to 12. But we further analyzed data and we identified some of the predictors of success. One of them was attendance. So we really thought that we need to increase that attendance through, to better retention. And also another one was being ready to quit. So we needed to think about how we can make the participants more ready to quit, and also incentives. And there were no difference between 2 arms, which was a good news for us, because then we invested more on the group, since it's less costly and we can reach out to more participants at the same time. And so retention became the priority for the next phase. And as you see, we learned lessons and we designed the phase 2, which is kind of changed. Now in phase 2, instead of clinic, we had these group sessions in communities. So in churches, in schools, in workplaces, and also instead of nurses and internists, we recruited peers who have minimum qualification. We trained them to become peer motivators and facilitate the sessions. And we added motivational interviewing to make people ready to quit. And also we kept the Fresh Start curriculum, but we put more emphasis in coping with stress and withdrawal. We created a nicotine replacement therapy voucher to ensure a better and more immediate access to these treatments. We changed the group dynamics, so it's a closed group, and now we have more peer support. And then revise the incentives. Instead of, in addition to the monetary incentive, we create a point system. So they get points and they get status, and their status increase when they go through the process. So, and this is the curriculum, the first module. So it was divided to 2 modules, one for quit smoking, the second one for staying quit. And the first module is for 6 weeks. And the next module is like 3 scheduled sessions and 3 optional sessions. So, for those who wanted to come, additional sessions. And so we are still collecting data for phase 2, but this is some of the preliminary findings of the wave 1 and wave 2 out of some of 10 groups that we have had. And the preliminary data shows a very significant increase. It's like odds ratio of 4.4 in quitting cessation outcomes, and also we have achieved retention rates of 53%, which is 4 times higher than the previous phase. And so that is another proof that community campus collaboration can be successful. And the main reason is if you create those kind of dynamics, you create knowledge that leads to action, and action stimulates knowledge. Thank you for your attention.